Hello, I'm Duncan McCormick. I'm a public health consultant and I'll be chairing this event today. So welcome to the webinar on the national implementation of the new standards for medication-assisted treatment. The webinar has been developed and supported by the Drugs Death Task Force of Scotland, Public Health Scotland and the Scottish Drugs Forum. The webinar will run until 2:30 p.m. We have presentations from 7 speakers. Some of these are recorded and some of these are live, like me. After the speakers, we'll have a session on questions and answers. So people viewing, to submit questions, there's a chat function on your screen. You can submit via the control panel, which should be on the right side of your screen. So first of all, I just want to give a little bit of context and background, and I've got a couple of slides to show about that. So this slide is about diffusion of innovation. This is the approach we've been taking for the development of these standards over the last 2 years. And this has been a really successful approach over the pandemic with fantastic participation from people who use services or have used services, people providing services, and increasingly with statutory organisations such as the NHS and Scottish Government. So this really indicates the process of new things happening, change happening. And we start off with the innovative on the left-hand side, and then there are the early adopters, which are the people who maybe want to start trying out new things, pragmatic people. It moves along through to conservative people who maybe take a little bit longer, and then people who are maybe a bit more skeptical. All these roles are important though, and to make sure that things are done properly. The approach we've been taken is to do quality improvement work and to start pretty small, which we have done, but we've been thinking big. So we started with small QI projects. We've been thinking about much bigger system change nationally, and we've also acted fast and shared learnings throughout the whole process. So you can see there's a big arrow there. That's around about 16% of people. When we get to that stage, then we reach the tipping point. And between where we are now and that tipping point, there's something called the chasm, which is a barrier we need to get across to move from something being unusual, such as starting treatment early, to being normal, such as starting treatment early. And I think that's where we are now, this tipping point. And we've really got an extra help from the Scottish Government with the increased funds and support to push us across that chasm into the space of sustainable change. So in terms of that change, next slide, please. It's clear that it's lots and lots of small steps to get there. It's not one big step. You can see the ladder. And so today we're going to have some presentations from people who are making those small steps. There's Lynn Drysdale from Edinburgh Access Practice, who's been working on Standard 1, access to treatment. There's Trina Ritchie from Glasgow, Alcorn Drug Recovery Services, working on Standard 2 around choice. Dave Taylor from Aberdeenshire Drug and Alcohol Services, Standard 3, which is about assertive outreach to ensure that people can stay in treatment. Jen Opera, Craig Miller Medical Group, around harm reduction in medication-assisted treatment, that's Standard 4. And then we'll also have some presentations from Tracy Klosker and Becky Wood, who are on the MAT implementation support team. Prior to that, though, we are going to hear from Minister for Drug Policy, Angela Constance.
Good afternoon, everyone, and thank you to the Scottish Drugs Forum for inviting me to speak today. The medication-assisted treatment standards were published on Monday the 31st of May and will represent a turning point in how people with problematic drug use in Scotland will be able to access the right support for them, regardless of their circumstances or where they live. Publication of the new standards follows on from consultation with a wide range of stakeholders. An interim report was published setting out the consultation feedback in March of this year. The standards also reflect additional feedback from stakeholders following that interim report too. And I very much welcome the publication of these 10 new standards of care and treatment for people living with the impact of drug use. Their development is a significant achievement, and I would like to take this opportunity to thank the Drugs Death Task Force, the MAP subgroup and the MAP programme team for all of their work in developing the standards. Implementation of the standards is one of the priorities of the national mission to save and improve lives announced by the First Minister in January. And when I made my statement to Parliament in March, I said the standards would be game-changing in the way that individuals access and receive support, particularly because these will help to ensure that more people receive same-day treatment. They will reinforce a rights-based approach by ensuring that individuals have choice in their treatment and are empowered to access the right support for where they are in their recovery journey. Today, I also reiterate my commitment made to Parliament to ensure the standards are embedded across the country by April 2022. So what is new about these standards, and why do I say they are game-changing? Firstly, the standards set out what people want. These are the things which the majority of people have been asking government to put in place. And I recognise that some of the ambitions are not new. But this is the first time we've brought together all of these requests into a single set of expectations for drug treatment. And what's really new here is that with the standards comes a fully funded implementation resource to help local services focus on delivery. So the MAP standards themselves and plans for their implementation will be a first in Scotland. I think one of the most important changes we want to see delivered through the standards will be the implementation of same-day prescribing options across the whole country. This will be groundbreaking and will ensure a holistic, trauma-informed approach by putting the person at the centre of their care. And whilst the concept of same-day prescribing is not new, we can learn from initiatives which are taking place at the moment in Scotland, elsewhere in the UK and abroad too. For example, Daniel Ahmed and the team at Foundations had been offering same-day prescribing in Middlesbrough and Hartlepool for a number of years to engage people and retain them in treatment in a person-centred way. In Hong Kong, opioid substitution treatment has been prescribed since 1972. That has been done successfully through the inclusion of important standards which make them easy to use, such as operating a low threshold model, meaning there are fewer conditions, so there are fewer barriers for people getting started into treatment. In addition, in various sites across North America, supported by Vancouver Boost, they have been offering some same-day low-threshold prescribing too. And studies have shown that low-threshold models of treatment increase the effectiveness of OSCT, increased availability, cuts waiting lists. And the low-threshold model also allows for more personalised approach to medication doses and flexible treatment lengths. I also think it's important to mention that over the last 18 months, areas across Scotland have been doing quality improvement work to develop models of low-threshold prescribing. This has included some same-day prescribing to reduce barriers to people accessing MAT and to increase numbers of people accessing treatment. And the standards will ensure services are available and accessible to people, no matter their circumstances. And a system of quality assurance will be established to ensure sustained change is achieved for the benefit of everyone in need of support. Most of all, though, publication of the standards and their implementation will be central to delivery of key parts of the national mission. This includes long-lasting buprenorphine in prisons and in the community, heroin-assisted treatment, integrating addiction services with mental health and homelessness services, increasing the availability of naloxone and whole family approaches to drug treatment. And all of this is aimed at raising awareness and changing practice to support people to better understand what they can expect or should demand for services. And I'm aware of the growing harm being caused also by the use of street benzodiazepines, and addressing this is also a top priority. And we have to understand what the reasons are for people using these drugs so that we can reduce the demand and the harm. I recognise that reducing harm requires more than just action to disrupt supply. Improvements to treatment and improvements in other aspects of care are necessary to stem that demand. To tackle this problem, we are taking a four-pronged approach through the national mission. Both the Drugs Death Task Force and the Scottish Government have complementary groups working on prescribing guidance right now. I am also pressing the UK Government to make progress on legislation around pill presses. This is something which Police Scotland have been asking for to help tackle the growing supply. And the fourth prong of our approach will be through the introduction of drug checking. And again, this is something I'm working with the UK Government to get set up. And I know that problem drug use can be the symptom of much bigger issues. The complex problems that people face must be recognised and tackled. For instance, we know that at least half of all people with problem drug use are likely to have mental health problems too. Therefore, we need to do more to improve integration between mental health and addiction services. And that's why I'm working closely with other ministers from portfolios such as mental health, housing, justice and children and families. And together, we are already working alongside senior representatives from organisations that deliver various related strategies and services. And I want to emphasise that whilst the implementation of these standards of care and treatment will be a core task of the NHS and social care services, it will not be down to them alone. It will require an all-government and an all-Scotland approach. And the role of the third sector organisations who provide frontline and grassroots services who serve individuals and communities is vitally important. To progress this work, to reduce deaths and to improve lives, we have committed an additional £50 million per year for the next 5 years. 4 new funds totalling £18 million opened at the end of last month to improve and accelerate treatment and recovery. And these funds will be in place for the next 5 years to allow services to plan for the future through multi-year funding. Today's launch event will showcase work in some local areas and what has been done to embed the standards into daily practice. The work which is currently being undertaken is both inspiring and encouraging, and I hope those in attendance today will also be encouraged by what they hear. And I also want to recognise and show my appreciation of the work which has been undertaken and pioneered by dedicated individuals and small teams, and the learning that can be taken from this work. With the publication of the standards and the extra funding, this effort must now be scaled up nationally, and I expect all health and social care partnerships and alcohol and drug partnerships to get behind and support this national scale-up. I want to finish again by thanking all of those involved in the development of the standards, but now we must move on to action and sustained visible improvement. The number of drug deaths in Scotland is a public health emergency, and the embedding of the standards will not only improve lives, but ultimately they will save lives by getting people into the right treatment for them at the right time. It is now time to turn words into action, and for all of us to strive to provide the very best of care and treatment with dignity, choice and compassion at its very heart. Thank you very much.
That's Minister for Drug Policy, Angela Constance. We now have a presentation from Lynn Drysdale, who's been doing some innovative work at the Edinburgh Access Practice for the Homeless in Edinburgh.
Hi, my name's Lynn Drysdale. I'm a community mental health nurse and independent prescriber at Edinburgh Access Practice, which is a primary care GP practice that supports people experiencing homelessness within Edinburgh. The following presentation is about a crisis intervention project for people experiencing homelessness and substance misuse, which was initiated during the first lockdown in March 2020. We're going to look at what the project consisted of and what's been happening a year on via patient feedback. So the first lockdown brought many challenges to people, vulnerable people experiencing homelessness, and many had no access to accommodation and were placed in hostels and hotels. This was additionally compounded by difficulties in accessing the welfare system and clampdowns on street begging and the disruptions of the supply of illicit drugs. Many were identified as not being engaged in any form of MAP, which we know is a protective factor from drug-related harm. So how was this achieved? This was a quality improvement project underpinned by evidence and with public health support. And it was to find those people most at risk of drug-related harm by going out on foot to offer harm reduction and rapid access to treatment with a trauma-informed approach. As can be seen from the slide, this covered a number of the MAT standards. So off I went with the rucksack filled with injecting equipment, foil, naloxone, point of care toxicology dips, registration forms and a pen and a prescription pad. It's important also to have an awareness of risk, and stringent checks were employed to keep this as low as possible. So off I went on foot patrol. There's also a drop-in clinic established in partnership with the Salvation Army at Nhs Street to allow for initiation of treatment and to follow up patients already commenced. A trauma-informed harm reduction approach was really important in that it allowed for an open and collaborative discussion, the use of drug use and treatment options. This approach fosters autonomy, choice and empowerment. So what happened, 17 people were commenced on OST on the same day. Age was between 17 and 35 and were mostly male. The majority had complex needs, physical health needs, mental health issues, and required access to wider primary care and support. And this was achieved by outreach work done by GPs and practice nurses into the hotels and hostels. There was issues around risk assessments due to a lack of methadone supervision by community pharmacies, but it wasn't possible to commence people in treatment. Although the preferred choice of treatment is buprenorphine due to its safety profile, we also did commence on methadone too, with good harm reduction advice and overdose prevention advice also. No near-fatal overdose incidences were recorded through same-day prescribing within this cohort of people. So what learning came out of this initiative? Good partnership working was essential, and this was achieved via liaison with colleagues at Streetwork and the Salvation Army, who proved to be essential in directing patients to me and in letting me know where patients may be begging, so I could go out and see them on their pitches. There's a need to develop further hospital assertive outreach required to reach people whose services fail to engage. And it's not just about OST, but the wider drug harms and the causes of drug use in the first place. This includes BBV detection and psychological input. The majority of people that I work with do have complex trauma, and the script of trauma-informed initiation of OST is important, but many cite stability as when the real hard work starts, when they have difficult emotions to deal with, and that's when we can go in and do some trauma-informed interventions. As a mental health nurse and independent prescriber, it was not only the initiation of OST, but the ability to provide relationship-based, consistent professional input and to address trauma and subsequent emerging symptoms of mental health. The people that use the service spoke highly of the autonomy and responsibility about making decisions about treatment and found this really empowering. That's something that really came out of it, that to be able to actually discuss treatment options and have some say in them was really important for them. So as a nurse, it was a really frightening and challenging time, but hopefully this project should contribute to new ways of working for people that use substances within Scotland. So this is really the most important bit, I think, of this presentation. In March this year, I requested some feedback from a few of the patients that I started. Basically, I asked them, if they'd been in treatment previously, what was their experience? What, if anything, was different this time? And where are they now? What's happening now? And I think the feedback really speaks for itself. The access to Hep C treatment, feel healthier, no longer wake up ill every day, best of all, I can smile again, having clarity to face life's challenges and where they want to go from here. And I think these are the voices that really need to be listened to and, given credit, because these are the people that are the experts and that are most needing to be heard. So to conclude, this project really covered MAT standards 1 to 5, same-day access, choice, assertive outreach, harm reduction and retention. It also can be referenced to other standards involving trauma-informed care and support prescribing around mental health issues. Right, finally, here's my contact details if anyone would like to get in touch for more information. Thank you.
Thank you, Lynn, and I completely agree that last point you made around people using services, seeing a difference is key to any change, and I think you made a very good point there, and that's also a central part of our programme. We'll hear more from Becky about that later. So now moving on to a live presentation from Dr. Trina Ritchie from Glasgow Alcorn Drug Recovery Services. Thanks, Trina.
Thanks for inviting me to talk today. My name is Trina Ritchie. I am trained as a GP, but work full-time in Alcorn Drug Recovery Services in Glasgow. And as Duncan said, asked to speak today about our experience in Glasgow working towards MAT Standard 2. MAT Standard 2 is about supporting people in their choice of OST medication and dose. In terms of medication, when I was preparing for today, I was reminded that when I started work in specialist services in 2004, we were piloting the new buprenorphine tablet in the north of Glasgow, treated 37 people with it. They had a great experience with it, and buprenorphine tablets were added to our formulary as a treatment option in 2005. Until that time, methadone had been the only option for OST treatment. Methadone and buprenorphine remained the two treatment options for 15 years until a new long-acting injectable buprenorphine product became available. In the spring of 2019 in Glasgow, we started a Buvidal pilot in the south of the city, offering the injection to 20 people who were already on OST buprenorphine. We really deliberately chose to offer it to people who were well established in treatment, so together we could get some experience and confidence in the new medication. As you can see from this slide, the pilot was a great success, and the 13 people who opted to try the new Buvidal injection described it as a game changer in their recovery. Later in 2019 in Glasgow, a heroin-assisted treatment service was established in the city centre in response to a needs assessment that was prompted by the ongoing HIV outbreak in the city. Some of my colleagues are speaking about this in more detail in a webinar on the 22nd of June. So where are we now in terms of being able to offer choice of OST medication in Glasgow? Currently, 4 out of 5 people in the city are on methadone and 1 in 5 people are on buprenorphine. In the specialist teams, 25% of the people on buprenorphine are on the new injections, and we're continuing to work to offer it as an equal choice. It's really good to have a new treatment option after all this time, but we do have to remember that it's not for everybody, so equal choices between methadone, buprenorphine tablets and the injection is really important. This slightly complicated slide, which some people might have seen before, I think is just really interesting and I keep coming back to it. So it shows the results of a front door access audit in the south of the city in the summer last year. That top branch shows that there are 8 people who'd never been in OST treatment before, and their choices, 7 people opted to have a go with Buvidal injection. The lower branch shows 24 people who are being restarted in OST and the choices they made for this treatment episode, and then in the far right column, the choice, the detail of their previous OST treatment. One of the learning points from this and our other experiences of rollout of Buvidal treatment has been the importance of having champion staff who are really experienced and confident in their knowledge of medication choices, and who, in addition to offering equal access to 3 medications for people starting OST, really take the opportunity at points of interruption of OST treatment for whatever reason to review people's medication choice. An area that we still are working on is how we're going to offer Buvidal equally to people whose OST is provided by their GPs in primary care in Glasgow under an enhanced service agreement. I didn't want to speak today about OST medication choice without mentioning the impact of stigma, which still at times feels overwhelming in Scotland. Supporting someone in their choice of OST based on their circumstances and their preference and balanced with the information about treatment choices is really challenging if the conversation is happening through the lens of anti-methadone stigma. The second part of MAT Standard 2 is about supporting people with the choice of the most suitable dose. Again, I was reminded when I was considering what I wanted to talk about this afternoon about how recommended treatment doses have changed over time. When methadone was initially prescribed, it was prescribed as a maximum 30 milligram dose and a punitive detox for people if drug screening showed that they were continuing to use drugs. Over the years, international literature has strongly evidenced recommended treatment ranges and the need for OST treatment, which is not arbitrarily time limited. In Glasgow, in the couple of years before the pandemic, we were benchmarking our OST doses. This graph shows the percentages of people on OST doses that are below the recommended treatment ranges. It's difficult to interpret because it doesn't differentiate between people who are reducing their dose and detoxing off OST as part of their recovery, and those who are on a low dose and continuing to use heroin and other opiates. But looking at these graphs in the context of 7 out of 8 drug-related deaths in Glasgow in 2019 involving opiates gave us a real cause for concern. We have local and national guidelines. We also recently have a peer research report looking at both staff and service user barriers and facilitators affecting optimal OST dosing in the city. And there's the growing body of literature referred to in the MAT standards, which emphasises the importance of respect for people's autonomy, choice, and person-centred care. And I think getting this balance right is our current aim and focus, and an area that requires strengthening, ensuring we listen to and understand where somebody is in their OST treatment journey and find the right dose for that person at that time. The last part of MAT Standard 2 mentions dispensing arrangements. So that includes both the frequency someone attends the community pharmacy to collect 1 or more days of their OST, and also whether or not that dose is supervised within the community pharmacy. In 2020, the pressures of the pandemic on community pharmacy and our concerns about supporting individuals to stay safely at home during lockdown led to a review of risks and a large-scale change to people's dispensing arrangements, reducing pharmacy attendance for most people to once weekly. This has been really positive for almost everybody, and it doesn't appear to have increased harm, so we're really planning to continue with this approach post-pandemic. In summary, in Glasgow, we've made positive progress towards MAT Standard 2, and we have a focus for which areas we're looking to further develop this year. Thanks.
Thank you, Trina. That was really useful in a very large, complex situation such as Glasgow City. A very useful project to hear about. My next speaker is Dave Taylor, who's from Aberdeenshire Drug and Alcohol Services.
Good afternoon. My name is Dave Taylor. I'm currently nurse manager with Aberdeenshire Drug and Alcohol Services. My background is in mental health nursing, but I've been working directly in the drug and alcohol field now for 20 years, the last 16 of those in Aberdeenshire. I have been invited today to share our experiences in developing and implementing a test of change aimed at improving outcomes for those at risk of drug and alcohol related harm by assertive outreach. This test of change is inextricably linked to the standards 1, 3 and 9 from the newly published MAT standards. For those who don't know Aberdeenshire very well, we cover a large geographical area of nearly 2,500 square miles. Not too dissimilar in size to Argyll and Bute or Dumfries and Galway, but with a higher population. We do not have the population density of some of Scotland's larger towns or cities, or the density of support services, but we do have a few larger towns and lots of smaller rural and coastal villages and towns. Aberdeenshire in itself is a relatively wealthy area compared to some parts of Scotland, but with pockets of significant deprivation. And like many rural areas, public transport is a challenge and can impact on people engaging with services. So why do we want to do a test of change? Aberdeenshire is no different to many other parts of Scotland in having been affected by increases in drug and alcohol deaths in recent years. When reviewing these events, it is evident that there has been missed opportunities to intervene in some cases. For example, someone who has overdosed several times in the last year and thus been in touch with other health services, but no referral made to drug services. Opportunities to provide naloxone training to individuals and their families is often missed. Patients in treatment or using our needle exchanges have been asking for replacement naloxone kits in increasing numbers, having used it on peers. We often only hear of those events weeks or months after they happen. Assertive outreach for those already in treatment is well established in Aberdeenshire and coordinated through our third sector partners, Turning Point Scotland and Alcohol Drugs Action, but nothing targeting those not in treatment and those at high risk of mortality. Non-fatal overdose is a well-established indicator of future mortality. Likewise, being in treatment is also linked with better outcomes. The MAT Standards consultation gave us the opportunity to reflect on what we did and how we move towards more compliant practice. It was apparent that notifications for non-fatal overdoses in Aberdeenshire were few and far between, and not getting to services timely, and that subsequent pathways for medication-assisted treatment were causing significant delays of weeks before people started treatment. We needed better communication, better referral pathways, and faster access to treatment. However, this was to be done as part of a wider service improvement programme, including increased naloxone distribution, development of women's services, and improved access to treatment and support for those in the criminal justice system. In order for us to achieve this, we would need the buy-in and bring in all services from Aberdeenshire to work together in partnership. So the ARES team at the current moment has one full-time equivalent care manager who has access to Care First and other statutory local authority services if needed. We also have 2 community mental health nurses, one working 2 days, one working 3 days per week. One of the nurses is a nurse prescriber to allow same-day prescribing to take place. We have 1 staff member developing pathways 1 day per week, and we also have admin support who check for referrals and update GPs with regards what supports have been delivered to our referrals. These staff are all from within existing services, with some backfill monies we got from the Drug Death Task Force. We were already receiving notifications of non-fatal overdose from the Scottish Ambulance Service, but this needed improving and we needed to develop rapid pathways with other relevant services. Our aim was to see all referrals within 72 hours, and this may include weekends. Our services in Aberdeen generally tended to work 9 to 5, Monday to Friday. We were hoping to provide early and intensive support where appropriate to reduce risk of future overdose and fatality, provide access to same-day prescribing, naloxone, dry blood spot testing, physical health checks, provision of injecting equipment, signposting and onward referrals to appropriate services. In the last 6 months, we have developed pathways with the Scottish Ambulance Service, police, fire services, A&E, infection units and psychiatric liaison services. We are currently in the process of developing pathways with the local minor injury units in Aberdeenshire and with housing services. So how do we deal with the sharing of information, as this is something that is brought up quite regularly? Well, in most cases, it is by consent. The individual affected by the non-fatal overdose agrees to have their details passed on to the ARES team. We developed a referral sheet as an A5 pad or electronic form, which is filled in by the agency and emailed to the ARES team. However, I do think we are quite fortunate in Aberdeen that there is a general consensus that those being referred are at significant risk of imminent death, and as such, issues of individual safety outweigh those of confidentiality. This does not mean that we pass on information willy-nilly. We make sure that it is necessary, relevant, adequate and proportionate. I hope you can see this properly, but this is our referral forum, and as you can see on it, basically in the vast majority of cases, the only information we share between each other is name, date of birth and contact details. At the request of some services, we are introducing a referral phone line with voicemail. Some services told us that they had limited access to computers and limited time following 12-hour shifts to scan and email referrals. Instead, referrals could be done via a telephone referral system in real time. So we continue to adapt our service as we go on. Up till now, we have received 78 referrals and the numbers of referrals are increasing month on month. Despite the vast geographical area that we cover, we have managed to see 58 of our referrals within 24 hours and a further 15 within 72 hours. Only 5 haven't been seen within the time that we were hoping to for some reasons, and 3 of these were actually down to treacherous weather conditions over the winter period. For those requiring starting on medication-assisted treatment, we have managed to do this the same or next day. However, it's fair to say that we have not received the high number of referrals that we were expecting to. Instead, we have received a significant number of referrals for non-fatal overdose involving intoxication of drugs and alcohol and emotional distress, requiring mental health support at point of contact. And this is something that we've had to consider in terms of how the service looks moving forward. So moving forward, we're looking to extend our test of change for a further year to gather more data, but also to allow us to embed some of the principles within it into regular services. Due to the number of mental health referrals that have come through the service, we are looking to recruit an additional mental health nurse to the team to develop better links with the community mental health teams, provide short and intensive mental health supports. We are hoping to embed the telephone referral line system into how we receive referrals. And at the end of the day, what we're hoping today to do is inspire maybe some other services, whether you are working in a rural area or an urban area, that change is possible. And ultimately, at the end of the day, it is about helping people. It is about helping families, and it is about helping communities. By reaching out to those at high risk of harm or death, we can encourage individuals to take up offers of support, treatment, support families, and reduce drug and alcohol related deaths. These are just a few of the quotes from people that we have intervened with over the last few months. Thank you very much for allowing me today just to share our experience of our test of change in delivering an assertive outreach service in rural Aberdeenshire. If anybody who requires any further information or would like to contact myself, please feel free to email me. The details are there. Thank you very much.
Thanks, Dave. That was really good. And actually, I think this illustrates a really good example of how we want to work together with the fusion of innovation and benchmarking across projects. When I was working in one of the health boards here, we went out to visit Dave from Edinburgh, and we learned some really good lessons from what they were doing there. We took them down to Edinburgh and into the services there and made some great improvements. So this is a really strong part of how we want to work, is into organisational visits and learning. So we're now moving on to the next speaker, which is Jen Opera from Craig Miller Medical Group.
I'm Jen O'Para. I'm a practice mental health nurse at Craig Miller Medical Group. Within the practice, we're trying to work towards MAT standards 3, 4, 5 and 7 within our test of change. Craig Miller Medical Group is a modern GP practice based in the Ritchie and Craig Miller area of Edinburgh. Within the practice, we use aspects of the Alaskan model of care, which is NUCA, and it's relationship-based and it's person-centred. So NUCA means strength, and it aims for people to be partners in their care and recognises health holistically. At the heart of our practice, we've got care coordinators, and they direct the person to the best person in the team to support them. So in our team, we've got GPs, practice managers, nurses, practice nurses, mental health nurses, a physiotherapist, and we've got pharmacists. Further to that, we've got a link worker within the practice who can direct people to social prescribing options. Usually when it's not during COVID, we have had other organisations within the practice as well that support us, and we refer into such as counselling with health in mind. We've got ELCA for alcohol counselling. We've got Turning Point Scotland. We've got Nhs. We've got Edinburgh Leisure. We've had Edinburgh Community Yoga as well. So we work quite closely with other organisations to support people to access a wider range of services to meet their health needs. Practice mental health nurses have been introduced as part of the modernisation of primary care. We currently have 3 nurses within the surgery, including myself and my colleague and my line manager. The main part of our role is providing mental health care and support, including prescribing to people with mental health conditions that would normally be seen by their GP. And we also refer out to secondary care if we feel that's appropriate. We don't replace secondary care. So it's mainly like depression, anxiety, maybe stress, distress, grief, things like that that we provide support with. The other part of our role is providing medication assisted treatment for people that are under the GP's NES contract for enhanced services for substance misuse. So it's not secondary care, it's just people that are stabilised on their MAT prescription. The test of change. So having attended the MAT standards and the workshops, the mental health nurses within the practice had a meeting via Teams with Tracy Klusker to discuss a test of change. And we recognised that there was a lot of higher risk with our drug users due to the COVID restrictions, and most consultations were taking place over the phone. We didn't have access to the usual services within the surgeries or the conversations that we could normally have with professionals when they were holding their clinics within the surgeries, and we really valued that. We recognised that we were using more drugs, risks were increased, people were not being able to access harm reduction equipment in the usual ways, so we decided to provide access to harm reduction equipment alongside our usual BBV testing, naloxone, and harm reduction advice as a test of change. We also decided it would be useful to trial a 30-minute meeting with Turning Point Scotland weekly to pass over any of our higher risk drug users and provide them with extra support. So what we agreed was we'd phone, we'd do a video link every week, and we agreed that the GP link worker from Turning Point Scotland would contact the person within that week and then organise further assessment and referral onto secondary care along with support to access this. So as a model evolved, as the meetings went on every week, we decided to add in alcohol users as well, because we were recognising that they were also at risk and we couldn't kind of separate them. So we did add alcohol users in to access support as well. So meeting the standards, MAT standard 3, people at risk of harm are proactively identified and offered support to commence or continue MAT. So we did that via the meeting. Prior to the meeting every week, we would look at the NFO list or identify people that had destabilised on treatment or had self-reported higher risk behaviour, and then we would take them to the meeting, or if they didn't want that additional support, we'd support them ourselves with extra contacts until they had stabilised. So we also were looking to meet MAT Standard 4, where all people can access evidence-based harm reduction at point of delivery. We got some harm reduction equipment from the harm reduction team and some training, and we've got that in the surgery, so if anybody needs it, then we can hand that out to them along with harm reduction advice. We did this because we recognised that it might be more difficult to access harm reduction equipment discreetly in the local area due to sort of COVID travel restrictions. They might not be able to go to where they usually access it. So we met the MAT standard 4 due to that, and MAT standards 5 and 7, all people are supported to stay in treatment for as long as requested, and all people have the option to have MAT shared with primary care. So I think we meet these standards as all people that are in our practice stay in our practice list. So we have an on the day appointments, so people can access support if they need it, or if they needed to speak to us, they could use one of these calls and we could direct them to additional supports. Also, we have we do prescribe MAT and provide that service for people that are stabilised on their prescription. We also support people to access secondary care for MAT, and we'll support them until they have their appointment there, and alternatively when they're finished their treatment with secondary care, we'll take them back and support them in the practice. So learning from the test of change, we're still evaluating all the data at the moment, but it's been really helpful to have the meeting. It was nice to see our colleagues at Turning Point, and it was good to have feedback on how people were progressing. There's lots of good work came of the meeting. People have been able to access alcohol detox. People have had assessments for restarting their prescriptions. Maybe they've been off it for a while, we're worried about them, and they've had opportunities, and other people that we passed over, they didn't maybe engage, but they've still had support from their practice mental health nurse. So it was really a good learning opportunity. And to finish off, I think we feel that it's been a challenging time working through COVID against the background of Scotland's concerning drug-related deaths. But what COVID has shown us is we can work in ways that are dynamic and imaginative and help reduce risks. Thank you.
Thank you very much. So that was really interesting to hear about that aspect of general practice care, which is important. So we're now moving on to some more live presentations. Firstly, from Tracy Klusker, who's going to talk about the medication-assisted treatment implementation support team, MIST, and then from Becky Woods, who is going to talk about the very important aspect of leadership around getting experiences from people who use services and their families as a gauge of whether or not we've been successful.
Thank you. So my name's Tracy Klusker. I'm currently the clinical lead for the medication assisted treatment implementation support team, and I'll be joined by Becky Wood, our community engagement lead, and I will just give an overview of how we intend to scale up the MAT standards across Scotland. So I think it's really important to say, as stated and you've heard from some of the speakers today, that we're not actually starting from a blank canvas. We've engaged with all ADP areas, we've engaged with health boards, people in recovery, people who have living experience of using services, and we have gained feedback from all stakeholders and to gain information how we can go ahead and now implement these standards. We have over 20 quality improvement projects that have already been undertaken, over 16 areas, all of which are unfunded, and some of them you've heard about today. Certainly we have What the Borders leading with some of the scale up of MAT standards within their current resources. North Ayrshire are involved in a very successful peer support in the Naloxone project, and CGL have distributed a number of kits using a peer model for Naloxone, as well as South Ayrshire. Mid Lothian and the Western Isles are doing some work along the lines of non-fatal overdose pathways in the way that Dave had described earlier from Aberdeenshire. Renfrewshire have been working very closely with us, and I would really encourage people to look at the task force website. They've written an account of their experience of implementing the MAT standards and some of the real challenges. So it's a very honest account of having a commitment, a desire to provide the best quality care for those that live in that area, but some of the barriers and how they're managing to do that and how they will overcome it. We're also funding some small projects in Aberdeenshire Borders, feature along the lines of advocacy, Dumfries and Galloway and Edinburgh Access Practice to look at Standard 10 and trauma-informed care. We have continual new requests to commence QI projects across all the standards, across all areas in Scotland, and we've had notes of interest from areas across Scotland to be scaled up via the MIST team, which I'll talk about the plans for that in a further slide. So the aim of the MIST team is to provide direct and indirect support for local teams. So this is to implement the standards. We want to collect evidence of success. So just in the way that Dave has spoken on some of the project work in the Borders, we want to share that innovation and learn from each area across Scotland to support areas to implement standards according to their local needs. We also want to find out, as Duncan had said, about the experiential aspect, which Becky will talk about. We really want to find out how people who are using services and their families are experiencing that, and if that has improved. We want to feed all the knowledge gained into a national public health approach for prevention, care and treatment for problematic drug use. So you can see from this chart, the three streams of work that we really are undertaking is intelligence. We want to gather all the intelligence from the learning across projects, including the experiential aspect of people's experience, and we will have a direct implementation and networking, which is led by myself and Duncan, and we will have pharmacy support, QI support, as well as a community leadership role, which Becky will go on to talk about, as well as the business aspect through the Scottish Government. So how do we plan on supporting the scale up? As said, we will continue to do the diffusion of innovation and work with teams on small unfunded and funded projects. We will give direct support for specific programme needs. So some larger health boards may wish to have programme management or analysis support to implement standards. We will be writing out in June this month to offer direct support for large scale up packages of care, which we would have a budget to support and resource for the areas that wish to, and we have had areas come forward saying they would like to be part of a scale up, so that would be a larger piece of work giving intensive support to those areas, and the indirect support through the collation, analysis and dissemination of learning from all the projects that have been implemented. So what are our outputs? Our outputs are the knowledge, so we want to inform a national business case for sustainable care and treatment by April 2022. So all the learning in terms of resource and process mapping will allow us to see what is the cost of a good quality service for people who are using drugs in their families. We want to benchmarks, we want to promote continuous quality improvement through progress monitoring and participation by November this year. And in terms of the implementation, as you heard the Health Minister say, we do want to, by April 22, really focus on that low threshold access for people to access prescribing around MAT Standard 1 and 2 for choice. We will be using the scale up, and we would look to target 6 ADP boards and offer funds programme support. So the delivery of the MIST scope of work is really dependent on this continued collaboration. We've had huge engagement very successfully with a range of multi-agencies from drug services, recovery services, advocacy services across Scotland, police custody, the prison, Scottish families, and more importantly, people who are using services. We need that to continue to build on the momentum we already have. And we also have support from the Scottish Government in terms of workforce development going forward, the creation of a national network for care, treatment and community participation, and the high level accountability. So these standards are different in that we would want areas to be accountable for delivering them, and we need sustained funding for services going forward. I'm now going to pass you on to Becky Wood, my colleague, who will talk about the experiential aspect of the MIST work.
Thanks, Tracy. That is people who are looking to access services, family members, staff in organisations, other supporting services or outside organisations. And we intend to do this by creating a simple assessment tool that will support services to identify specific changes and highlight the experience of people who are seeking help for their drug use in Scotland and the impact that MAT's having. So that could be things like same-day prescribing. Work's ongoing in developing a package that can be easily utilised by health boards and delivered by a tranche of trained quality assurance and improvement analysts who can gain insight into an individual experience of the impact of the implementation of MAT standards. The work will be carried out by experienced trained members of Scotland's community of people interested in supporting the MAT standards and moving this forward. And they'll have a unique experience of addiction, of services and MAT. This qualitative work will complement the quantitative measures that are being undertaken and will inform successes, difficulties, best practice, challenges, and it's not designed to highlight shortcomings, but rather provide an opportunity to share successes and support areas that might need improvement. So the work to date has included a question testing exercise with a small group of people who who are experienced in engaging with existing services. Sorry, I'll say that again. Our next steps are to identify health board areas and organisations who are early adopters of the MAT standards as pilot projects, and further test out the quality improvement programme. And this will inform a rollout of the work across all areas of Scotland. I'll just finish with just a little update on my role within the second phase of the DDTF, which is to continue to inform and seek guidance from experts by experience, recovery organisations and other organisations and family members across Scotland to voice their views at the task force core meetings. Thanks very much for listening. I'll hand back over to Duncan.
Okay, so I should introduce myself. I'm the Austin Smith from Scottish Drugs Forum, and I have been asked just to chair this, or sorry, not to chair, just to facilitate the questions. The questions come in through the chat. So when everyone was doing the presentations, there were some questions coming in, but there's certainly room for more if anyone has any lingering questions from as a result that have come up through the presentation. I think it's fair to say, in summarising the questions, a lot of the questions have been about resources and the possibility of new resources or resources to implement the standards. So I suppose in compilation, the question is, or the point is that a combination of swift access and improved retention will mean that there are more people in services, and so this has resource implications. And the concern is that, or part of the concern would be about the danger that money would be diverted within the existing service budgets away from, for instance, alcohol treatment into drug treatment. So is there any indication about how those new resources or that new demand will be met?
I think it's a very important question, and I think more than one person needs to answer, but I want to start with Jamie, who's got some insights into the implications, I think, and then we'll go to Trina, and then Tracy can follow up. So, Jamie.
Yeah, thanks, Duncan. So I suppose what you're describing, Austin, is very much the boarders' experience. So we moved to a low threshold model with same day prescribing over a year ago now. And I think what you can take from our experience is that it really does work. So we've seen an over 30% increase in the number of people maintained in treatment over the last year since we've done that, which on the one hand has been absolutely fantastic. But one of the real challenges that we're now facing is that obviously that means that, particularly for our key workers, is that caseloads have just relentlessly gone up over the last year. And I think we are actually really starting to see the pressure on that actually in staff, particularly because the standard has changed. So whereas, a few years ago, perhaps if someone, had fallen off their script, it would be kind of a feeling of, well, we'll get them back on when we can. Whereas now very much the culture in the team is we would try to offer them access back onto OST, the same day or within days, if at all possible. And while I'm 100% behind that, we do have to recognise that has actually puts an immense amount of pressure on staff. So when you combine that pressure of doing things much faster for patients with the fact that your caseload, has gone up by 30%, absolutely, the question we have to ask is how is that sustainable in the long term? And I think certainly from our point of view, there are two aspects around that. So one is that obviously, we can innovate and we can adopt different ways of working. So things that we've done in the borders is, prior to COVID, we had drop-ins. And actually what we found is that a drop-in model does allow you to manage some of that demand, because you can plan to have staff, including a prescriber, available at a drop-in, and you can invite patients to attend at a time that suits them in that drop-in window. And that takes a lot of pressure off of a key worker to arrange a traditional, here's an appointment slot with a prescriber to get you restarted, and that's really powerful. But I think we also have to recognise that, as well as innovation, that there does come a limit, and actually at some point, to maintain the service, the bottom line is we will need more resource. And I suppose, like everyone else, we are waiting on Scottish Government to hear the details of how that's going to work.
Thanks, Trina. I think that's a good explanation from the Spectrum Board. Sorry, Trina, you go ahead. Yeah.
Just without repeating things, totally agree with the points that Jamie's made. And yes, I think that it's like a perfect storm of improving practice and changing approaches and the pandemic happening. And also I would have to mention that although the small time limited funded projects are really exciting and can bring really good change, they are actually a really concerning drain on experienced, knowledgeable staff who are, seconded out or join some of the time limited projects, which actually means, that we do have a lot of pressure in just our main treatment and care services. So everything that I said about what's happening in Glasgow is describing our, you'll notice I use the words aims, focus and points for development and avoided the big but I would echo that without resources we'll be very limited in the sustainability and the change and the quality that I was talking about in actually implementing.
And Tracy, do you want to come in there?
I thought, what you're describing, Jamie and Trina, is not unusual when we've been out to engage with different areas. Some areas are doing things like drop-ins, and I had quite a lot of note of interest now that things are opening up again and the pandemic appears to be settling. People are wanting to go back to try and drop-in models, because that did actually, the feedback from people using the service was really, really positive. We are trying to get areas to consider more primary care, if that's someone's choice to be managed in primary care. Is that a model of care to allow that exit strategy? And it might be, some people using services might see that as really positive for them. We also have other areas doing having third sector doing some of the sort of key work in psychosocial support, recovery communities being involved. So there's that kind of wraparound care for people whilst they have a prescribing assessment. We are engaging with community pharmacy as a more role for pharmacy to be involved in terms of going forward to create capacity, doing some innovation around community pharmacy. And I think one of the other significant things is that what do people actually want from services? When we talk about the quality of care, is that based on service need, or is that based on what people are actually wanting to receive, be that too little or too much? And I wonder, Becky, if there's anything you want to say from the perspective of people who are in service or accessing service.
Yes, I'd agree with you, Tracy, that I think organisations like the recovery communities that are well established can provide that sort of additional support and really good communication between organisations, so that there can be, things like premises available, perhaps. The recovery community can maybe offer space for workers to go and engage with people who are waiting to see somebody, and have that sort of additional support there. So yeah.
Okay, I think that's a good range of things. I can give you one other contribution from talking to Scottish Government colleagues, is that the workforce capacity, workforce development is something very much on their agenda, which they are tackling, because it's very clear without that, sustainability is going to be very difficult, even with all the extra things that Becky's talking about. We do need to have increased capacity. So that's that. Next question, please.
Thanks, Duncan. A couple of questions, or maybe three questions I can combine around a kind of ADP perspective. One of them being around their own performance being monitored and assessed in terms of MAT delivery, but that MAT delivery largely being in the hands of the NHS services themselves. So how can they monitor and contribute to that, and then be assessed on it themselves? And also a concern that so much of the commissioning has been done nationally, that locally ADPs won't be able to monitor or drive change locally. And a sort of broader question about NHS culture, which I suppose the question is, does the MAT standard implementation involve a change in NHS culture?
Okay, there's quite a few questions there. I'm going to start with one of them. So in terms of accountability, the approach that the MAT implementation support team MIST will take is it's a quality improvement approach. And it will involve benchmarking, and that benchmarking can be done at two different levels. One, we'll be asking, working with ADPs to collect data. So data on process, what protocols are in place, this kind of thing. There'll be a request, and it's in the MAT standards, about collecting data, for example, on how long it takes for someone to get onto treatment, what proportion of people are on Buvidal versus methadone, what's in patient of choice. But the really important part of the data is what's the experience of people using services and their families. If those experiences are not improving, it doesn't matter what the data, the numbers say, and the protocols are in place because they've not been successful. So this is the quality, and that's the way we'll be doing the benchmarking, which will be through a sort of networking approach I mentioned before, interorganizational visits and so on. So this is about how ADPs can work with themselves and amongst themselves and with health boards to be accountable, to have that internal accountability. The other thing is it's about the across boards, because health boards frequently incorporate more than one alcohol and drug partnership. I think there's 7 in Glasgow, there's 4 in Edinburgh and so on, in Lothian rather. So what the MIS team will do is offer program management support to each health board in terms of funding for a program manager. This goes some way to helping have a management approach across all the different areas, but it's not enough in my view. And the accountability really needs to be put into place and guaranteed by the Scottish Government Implementation Group, which is meeting its first meeting next week. It involves ministers from mental health, from justice, from drugs policy, and there are CEOs from statutory and third sector organisations on it. This is where the support has to be given for accountability. And one of the things that we'll certainly be recommending is that in the same way that's happened for mental health services and perinatal mental health, and in fact also for things like the hepatitis C action plan, which was a great success in Scotland, is that by health board there needs to be some form of program board or something like that, which takes responsibility across all of the ADP areas for providing a consistent approach. Otherwise, one of the aims of the MAP standards is to promote consistency. Without that, I think it'd be very difficult to do. So that's other areas of accountability. We are working with Healthcare Improvement Scotland, HIS, in order to translate these standards into a more formal way of measuring and accountability, but that's something which will be informed by the learning we get from the implementation work. So that, I hope, answered a little bit about the accountability side. There was, I think, another question in between, but the last question you had, Austin, while you remind me what the middle one was around, is this going to require a change in NHS culture? And I think it's probably not just NHS culture, but I'm going to ask, I'll start with Becky to respond to that one.
Yeah, well, I can't answer the question about whether it's gonna, there's gonna have to be a culture change. What I can suggest is that the quality improvement work toolbox, if you like, that services will be expected to carry out should be able to guide the ADPs. Then that will give ADPs an indicator of what is expected of them, what's working well, and what needs to be improved. And I think that there might be something around here about ADPs, health boards, and third sector organisations, providers, basically being a little bit imaginative. And we've heard some examples of that this afternoon. And doing what they can, doing what they can to make sure that the MAT standards are implemented. The experiential work will inform that. So we'll be able to give a clear idea to organisations whether they are going ways forward in actually implementing the MAT standards. Where areas are having difficulties, then we can provide support then and examples of how other areas are getting around particular issues, a bit of communication there. I think ultimately this is to prevent death, and this is to make a system that is struggling a bit at the moment work more smoothly and actually have positive outcomes, which is less death. So I think whatever the ADPs can do to sort of support this, It was quality improvement and quality assurance that we would be expecting of people.
Thanks. And I'm going to come to Trina in a minute to answer the question about NHS culture. So you've got a few seconds to think. But I think there is that definite issue in Scotland of ADP, responsibility and accountability, and then the NHS, because things are not joined up as nothing's joined up as one would like it. But there is those two levels really, ADP delivery and then NHS, and I think that's where what I said before comes in with it. But Trina, you've had time to think about the culture change, so on you go.
Thanks for my 3 seconds. Yeah, so I think the question was around, will meaningful implementation of the MAT standards require cultural change in the NHS? And I think I mentioned a couple of things in my presentation. I did mention stigma in general about OST, and in particular anti-methadone stigma. And yes, there's some of that in the NHS, and that needs to be addressed for meaningful implementation. Actually, in my mind, from my experience, it was non-NHS where sometimes that anti-methadone stigma comes from. So I guess I would, and sorry, and in my presentation, the other thing I spoke about was something which we are very much taking on board within treatment services, which in Glasgow are fully integrated NHS and local authority, which is around really finding that balance point of the information and maybe the provider view and the individual person's view, and getting a joint opinion about treatment, which I think, as I said, we could be much stronger about individualised care. So that's a cultural shift. But I think in general, for meaningful implementation, everybody needs a shift in culture and attitude to some extent. Some people much more than others, some organisations much more than others, and about different things. The MAT standards are actually really wide ranging. They're touch on a huge number of things. So absolutely yes is the answer to the question, but not just the NHS.
Thanks. And I don't know, Jamie, do you want to say something?
Thanks, Duncan. I won't repeat because I agree with everything that that Trina's just said. I suppose the only comment I'd make is that I think Trina's right that it is the NHS, but it goes sort of beyond beyond just the NHS as well. So to give another example locally, so one of the things that we've done to meet MAT Standard 1 in a rural area is we've started using telemedicine and remote prescribing, and that's been massively successful. We've not had any incidents or overdoses around that, but essentially we've been able to do that because of COVID, because COVID has created this culture where all services are willing to try new things. And so our community pharmacies have been willing to accept scans of prescriptions from us, with the paper prescription following after, and that's let us remotely start people on MAT on the same day. Now, of course, COVID is coming to an end, and colleagues are starting to say, well, this is a local agreement, this is not within the national rules, this has all got to stop. And it's immensely frustrating to see that culture that just extinguishes innovative ideas because it runs up against sets of rigid rules and inflexibility around that. And I suppose what I'd really be hoping that the MAT standards give us the opportunity to do is to look at all of that with support from the highest levels of government to say, how can the NHS innovate, how can partners innovate, how can we all innovate together to actually maintain these sorts of changes.
Thanks, that's helpful. And Tracy?
I guess most of what needs to be said has been said. I guess it will be a cultural shift if we are being honest in some areas, in terms of there has been at times, it has been a very medical model, and I guess we want to move away and have a much more, people who are using services are in partnership and have representation from those using services and their families in the design of and implementation of the standards. So I think I think there will be some areas that are much more forward thinking, but some areas will need a bit of support to get there. And I think part of the MIST, the implementation team really is to support and understand what is difficult for areas that are, finding implementation difficult, to tease out what some of the cultural issues are in a supportive way, in the way that Becky described, because I think some people naturally are used to a certain way of working that makes them, feel safe, and we have to make sure that staff feel safe at work and that we're supporting people to do this in a way that has best outcomes for staff and services and the people who use the services most importantly.
Thank you. I think I'll just add one last thing onto that, which I think the culture change has to be in the public, the general population. There's a general population which votes in politicians, and there's politicians who make decisions about things. And I think there are reasons why certain areas of public sector services are less developed than others, and that's due to population, culture, and values. And so I think that's a big area of culture change, which I think needs to happen, and I think is beginning to shift a bit. Austin.
Yeah, a few questions. There's a lot of questions around prescribing practice, but one of them is a couple of questions about the broader thing about who can prescribe and whether prescription should be done by what in this question is referred to as non-medical healthcare professionals, and whether we can have prescribing through the third sector, and if there could be more flexibility as there is down south.
That's a good question. I'm going to go to Tracy first.
In Scotland, as within the healthcare setting, Trina and Jamie, you might want to add, and certainly in England, we've had discussions. They have a very different model where it is within, so it's a mixture of both actually. So the Middlesbrough model would be within, they have Danny's team working in that as within a GP practice. It's primary care, but they have Change, Grow, Live doing all the psychosocial stuff, the assessment, and that's a really nice model actually of care. They do employ in England, they do, MCGL do have people prescribing in third sector, but that's not something that's in Scotland. But we are looking, we're meeting with an area just to look at a prescriber being in place in third sector, but they still would have the governance under health. So where we are just now, it is within the NHS health services, but certainly across England, they have a different model to engage people. I don't know, Jamie, do you want to come in about what your thoughts are on third sector prescribing?
Yeah, so I suppose as Tracy says, I mean, the English model is very different, and I suppose from my point of view, I would say be careful what you wish for, because I think one of the real strengths in Scotland is that addiction services are still seen as a core function of the NHS, and I think speaking to colleagues in England, they are sometimes feel very trapped from the sound of it in a sort of cycle of commissioning, short contracts, but also with challenges as to how you develop staff, particularly, for example, in addiction psychiatry. So, as a psychiatrist, I see my role in the team very much not just around that, but also around, the mental health care, for people within our service. The training pace for addiction psychiatrists in England, have dropped considerably because it is no longer within the NHS, and traditionally it is the NHS that provides those training posts. So I think, just before I finish, this is in no way being negative about non-medical prescribers, which is a completely separate issue. And I think certainly in terms of non-medical prescribers within the NHS, I'm 100% behind that, and our team's just fought to get more funding to put more of our nurses through that training. So I think certainly we 100% need to be moving away from a traditional it can only be doctors. That definitely needs to be gone in Scotland. And my job as a senior clinician is to support my NMP colleagues. It's not to undermine them in any way. But I suppose I'd be very, very cautious. I'd be interested in what Trina thinks, but I'd be very cautious of saying that we in Scotland should move away from seeing addiction services as a core part of what the NHS should deliver.
Thanks. I don't know, we've got quite a lot of other questions. So Trina, do you have anything significantly different to what Tracy and Jamie have said? I suspect not. No, okay, good. I think that's a pretty clear answer actually from who we've heard from. So can we go on to the next question, Austin?
Sure, Duncan. I just to say to people that there are some very detailed questions, particularly for Trina, around her experience and the evidence base for practice and so on. And I think we could have a whole other webinar on that. I think in terms of the capacity of the system is the other big theme. And the last question takes into account a few questions that came through. Some of it focusing on rural areas, but how do we expand the capacity within GP colleagues to deliver on some of this? So the area that's mentioned specifically is that the Borders is a rural area, but there are other questions for Scotland more widely.
Yeah, rural is an issue. I think, Jamie, that's for you. Thank you.
Yeah, so GP prescribing, I suppose, is something that's done, very differently in different areas. And certainly, when I trained in Edinburgh, GP prescribing really is essential to the way the service runs. I suppose the challenge in more rural areas, and again, I suppose it's me saying, I think we have to consider very, very carefully how we would do that. So in Borders, a lot of my GP colleagues have made it quite clear that they don't really want to take that on. And I suppose the other challenge is that as a small rural team, if you took a significant number of our patients and handed them to primary care, you might actually need to divert enough resource away from our team that we would lose actually the critical mass we need to provide a really high quality service. So I suppose what I'd be saying is that my view of MAT Standard 7 is that it needs to be very carefully considered as to what's right for different areas. I really strongly feel there's not a one size fits all approach. And I think what's going to be right, in an area like, Glasgow or Edinburgh or Aberdeen City is probably not going to be right. And I suppose what we'll be doing with MAT Standard 7 is as a starting point, we'll be exploring with primary care colleagues here as to what they feel their role should be. And it may be perhaps, what I would love is moving to more of a collaborative model where maybe our team would be, supporting them to be involved in care with MAT, even if we're still doing the specialist prescribing. As I say, all of these things are very much on the table, but I think it's not going to be a one size fits all approach.
Thanks. I think that's certainly true with primary care. It probably works for most of the MAT standards actually elements because it's about being patient-centered, isn't it? So that's a good message from there. Austin, I'm just thinking about time. Do we have time for one more short question? Or do you have one more short question?
Well, I no, I don't. I think, Duncan, and to be fair to you, I think we maybe have to draw this to a close. Just to say to people, we will pass all the questions on, but there are a lot of them, but it'll form part of our thinking about work in the future in terms of webinars and other events. Thank you.
Good. Okay, thanks. So, well, we've come to the end, and this has been recorded, so it'll be published on the Scottish Drug Forum YouTube channel. So you want to see it, or friends of yours who couldn't attend can see it on there. Also on that website, there's previous webinars on subjects related to the MAT standards, and there will also be other webinars coming on to that website soon, one on benzos and one benzodiazepines on the 25th of June, and one on heroin-assisted treatment on the 22nd of June. The SDF will send out everybody an evaluation form, so it'd be really good if you could fill that out and let us know how to make future webinars even better. But with that, I think thanks for coming and hope to see you at the next one.